Good morning, George, and it's another Tuesday morning and another episode of the Pediatric Lounge with some phenomenal guests from across the country today.
Yes, today we have a segment of the Pediatric Lounge Innovation Sessions. And the topic that we're going to have today are accelerating innovation in the pediatric field of medicine, all for the benefit of children. And Dr. Sabrina Brum is going to be the host on this, and she'll introduce our guest. Take it
Hi,
away, Sabrina.
thank you. Hi, everyone. I am so excited for this episode. I think talking about how we can innovate for children is my favorite topic. And today we have two very smart, accomplished women who are leading the charge. We have Deepa Shah, who is the head of operations and strategy at KidsX and Children's Hospital LA, and Kiana Turner, who is the director of digital transformation at the Children's Hospital of LA and program lead for KidsX. So before we dive in, I'm wondering if our guests can help us understand the relationship between Children's Hospital of LA and KidsX.
Yeah, I'm happy to jump in here. So Children's Hospital Los Angeles, we have an Office of Transformation that Kiana and I are both part of. So our department includes an innovation studio that runs a lot of different programs focused on different things like care model innovation, clinical education, simulation. We have connected care programs like online second opinion programs, and then we have accelerators like KidsX. And so CHLA really serves as the administrative center for KidsX, and then our KidsX team works with 30 other children's hospitals that pay a membership fee to be members, a part of the KidsX program, and really use a lot of the programmatic work that we do as a team.
Yeah, Deepa,
Thank you.
what's an accelerator?
Accelerator is really focused on supporting companies that already have an existing MVP, a minimal viable product. They have established outcomes. They've already worked with a few different customers, whether they are hospital systems or clinics or whoever their customers are, but they have some establishment in the market, but they're really looking to scale and accelerate the growth of their company based on whatever their business goals are. So our accelerator program really helps them get to that place of scaling. We have curriculum built out to support their needs and then get them connected to our network of children's hospitals so they can work with them.
And is the accelerator program at your institution a residency? But do you have to be present in a co-working space, or can it all be done virtual?
Ours is live virtual, and that's really by design to make sure that we're able to support companies that are not, only in California or can only come and stay in California, but really are across the country and even a part of the world. We've had a few different internationally based companies be a part of our program. So it's live and virtual.
And do you have any independent practice um, models in the accelerator?
Practice models, can you
Yes,
clarify?
like not a disease specific, but for example, I I have one successful two-person pediatric practice, and I now have two, and I'd like to accelerate that given my experience running these practices.
Yeah, so we don't necessarily support practices yet. I think that's something we're definitely open to. This is really more for digital health companies that are in the
Okay.
pediatric market looking to work with hospital systems.
Okay. Thank you.
So one of the things that pediatricians are watching closely is how children's hospitals are struggling, and some of them happen to be closing. And so I guess the first question I have about this topic is, how are children's hospitals thinking about innovation given the climate?
I can take that one. I think that innovation is a requirement in this day and age in order to make sure that we are offering a world-class patient experience, in order to make sure that we have differentiated ways that patients can engage with their information, with their services at our hospital. But at the same time, because we're in the PED space, we are all the more risk averse compared to the healthcare industry in general, which is already risk averse. So we definitely are looking for startups that have validated outcomes. We are looking for solutions that really align with our institutional goals. And we're not in the business of taking risky bets. We're more so I wouldn't say the late adopters, but we're not going to be the first adopters. We take a much more tempered approach to some of the newer innovation products that are coming on the market.
How do you think about institutional priorities? You mentioned that you try to find companies that align with your goals. How are you thinking about those?
Our institutional goals are aligned around patient acquisition, making sure that we are um, here at Children's Hospital, we will never turn away a patient due to their ability to pay. So we want to make sure that we are attracting a diverse patient population, diverse in terms of payer sources, as well as in terms of all of the other determinants that you can think of when you think of diversity. We are a safety net hospital, but we want to make sure that we are able to cover all of the patients, including those that are not able to pay for services. We also are very focused on workforce retention. We know that burnout in healthcare is a huge issue. And with PEDS, you're dealing not just with a single patient, you're dealing with perhaps multiple caregivers, mom, dad, siblings, or other family members. So there are multiple stakeholders and multiple patients or customers, as you can think about it, when it comes to the care that our clinical teams are providing. Reducing burnout and really retaining our workforce is also a really big goal for us. And then lastly, I would just say operational efficiency. We're always trying to do things better, faster, and cheaper.
How are the hospitals feeling the workforce crisis?
We are definitely seeing some of the same attrition rates, burnout rates as the rest of the healthcare industry. So we want to make sure that we are focused on innovation that not only supports our patient and family experience, but also that supports our physicians and our clinical teams as well. Because if there are ways that we can make their job easier, it's a win for everyone, for our employees and for our patients.
Give me an example of how you would make a physician's job easier.
So we recently rolled out an AI solution that ambient listens to the conversation in the room, that has the ability to capture multiple stakeholders, because as I mentioned, it might not just be the patient and physician talking, it could be additional caregivers in the room. There could also be translators or interpreters in the room, and basically drafts the clinician's clinical note so that they don't have to remember all of those things, do those things during pajama hours or after hours, as we call it, and gives the physician a draft of their note, both that can be copied into our EMR, as well as something that can be shared with the family and the patient for them to remember the pertinent points throughout their visit.
That's very, very cool. I like that. So it's basically scribes.
Exactly.
Okay. How would you respond to the physician that tells you, I have templates that do all this for me. Why would I need to engage this? It's just another nuisance thing for me to do.
We've started out with a pilot for those that were interested and willing to participate. We are seeing efficiencies over the existing tools that physicians were using. It's starting to gain momentum just organically by word of mouth, by seeing the efficiencies, by seeing the increase in physician satisfaction with their role and with their connection with the patient. Because they're not having to remember those things or type them during the visit, they're able to have more just face-to-face time with the patients and with their families. And we're also seeing an increase in patient satisfaction for those that are able to get this transcription after the visit.
I agree with the patient satisfaction. They love it. It's always about the patient. They love it. The doctors are the ones that don't usually.
And we made sure to do a satisfaction survey with the physicians that were part of the pilot, both before and after using this particular scribe tool. So we did ask specifically for metrics around their satisfaction with their role, but also their level of connection with the patient during the visit. So those are things that we're seeing significant increases on, and that kind of just sell themselves in terms of selling the solution throughout the organization. And again, it's very opt-in. It's for those that are interested and willing to participate. And then we'll figure out where we can scale.
You said a lot of wonderful things. Where does the outcomes come in? Because we know EHRs do not improve outcomes. If anything, they have decreased access to the most, or the people that need the most access, because of the way, and I think California is a lot better than the rest of the country, but how poorly Medicaid pays for the service pediatricians across the country. And then then you have to spend so much time charting, and then you don't have time to see patients, and then you feel exhausted at the end of the day. So how does this new technology improve outcomes? Are you measuring that?
We are. Some of the outcomes are more experiential, so around physician satisfaction, around patient satisfaction, but we are also looking at accuracy of diagnoses. We are looking at readmission rates, both to the ED as well as inpatient. So we do also look at clinical outcomes. The difficulty with that is that they often take much longer to measure and to see fluctuations with, but we set those up front. I would agree with you that the EHR is really, it's not going to impact outcomes. The EHR is the repository for information, but we're not yet seeing EHRs that are actionably improving or suggesting actions that can improve outcomes. So unfortunately, we have to invest in these bolt-on solutions to really make the information in the EHR actionable so that we can impact those outcomes.
You're a lot younger than I am, but the EHR was put as an albatross around our necks about 10 years ago without a choice, but it had been around for about 20. So it has had plenty of time to show that as far as improving outcomes, it's worthless in its current state. Now, how does this improve relationships between patients and doctors and doctors and doctors and nurses and doctors and physical therapists? How does this dictation improve, strengthen relationships?
I think for one, just the ability for doctors to really focus on their patients during the visit, to really have that eye contact, that face-to-face time, and not have to worry about spending time on a computer screen or writing down in their notes. I know you mentioned EHRs have been around for 10, 20 years, and I was a part of that implementation kind of boom, the meaningful use rush to get everyone from paper to electronic health records. While EHRs in itself aren't going to improve outcomes, I do think it creates an infrastructure for us now to have all of this data codified and discreetly captured so that we can do things with the data rather than sorting through static paper or even PDF scans into the chart. I think that having all of this data now, it's on us to figure out how we use it to predict where we need to intervene, how we use it to predict the patients that have the highest need and what needs they have. So I think we're just at the cusp of, now that we've got all this data in electronic format, what do we do with it? And what tools do we use outside of the EHRs? Because we don't necessarily see them incentivized to do all of this. What tools do we use outside of the EHRs to really improve those outcomes?
And how does this product decrease the word vomit and accuracy? Because I've tested a couple of them, and you can test ChatGPT, Claude. I think Claude is Claude 4 or something like that. And I won't say the other brands I've used. It is magical. However, I'll give you a recent example. I can't spell, I'm dyslexic. So when I write something, I write it, then it goes through Claude, then it goes through Grammarly to be able to publish it. And one of the physicians I really admire, his name is Dr. Orsini, wrote me back. He says, love the review of my book, Kurt, but you put my name as Orthini, not Orsini. And that was all ChatGPT. That was all artificial intelligence. It just changed 2 words in a very vital word. And I'm dyslexic and I can't pick it up. There's a real danger that might cost the life of a child if the AI mistakenly puts the wrong medication. Like just the other day, I used that, just like you said. I said, we're going to put amoxicillin 2 teaspoons a day for 10 days for your strep. Take all 10 days, because we don't really treat strep because it gets better on its own. But if you don't take all 10 days of your medication, you may end up with heart disease. So I want you to make sure you take your 10 days. When I went to look at the note, it said Omnicef. What did Omnicef come from? I have no idea.
I had the same thing happen. I wrote for Cefdinir and it came out as ceftriaxone. They're all cephalo somethings. It's not the end of the world, but
How did you come from amoxicillin to Omnicef?
I don't know.
And dealing with strep, what if I'm a cardiac surgeon and this is a post-op patient and I'm going through my routine and I'm busy, I have another emergency, I run to that, and the intensivist sees the medication list and it's cardiac medicine, and it's got different cardiac medicine than what the surgeon intended.
So are you asking about what the checks and balances are that the children's hospitals go through to ensure
Yeah.
that the products
I think
work?
there's real danger. I think there's a lot of promise in this technology, and it is wonderful technology. But I think that we also have to have a jaundiced eye in that it does still make a lot of hallucinations. And those hallucinations in a critical access unit could mean the difference between death and life.
That's a good question, I think, for both of you, is what are the checks and balances as you're implementing more AI-based tools from these companies? How are you thinking about the checks and balances that are required to ensure that you're not making risky choices?
There's definitely a lot of risk, but we view AI as an accelerator for some of the repetitive tasks that physicians and clinicians have to endure. Not at all the end all be all, sign it off and send it to the patient method. So we are definitely a proponent of making sure that the physician or the clinician signs off on anything that is transcribed by the AI tool before it's presented either in the patient's chart or to the patient. Before Children's Hospital, worked with Alexa, everyone's favorite and most hated voice assistant at the same time, because there are often a lot of errors with how Alexa may understand you. The issue is that if we don't engage, then the tools don't get to learn from our specific data sets. And we already know that there is a dearth of pediatric data in a lot of these AI tools and in the models. Boston Children's did a study not too long ago showing that ChatGPT specifically was all the more inaccurate for peds, contributing our information so that the models can learn, become more familiar with what medications are appropriate for what types of conditions, and make more educated suggestions that can then be signed off by a physician or clinician is definitely the process that we're looking at.
I'm
Yeah,
going
I
to tell a
completely
really funny
agree.
story before, and then I'll be quiet. But I had the pleasure of hosting Dr. Rogel and the better Dr. Rogel Delia at my house. And I am a total Apple fanatic. If you ever want to give me a great job, Apple, I'm available. But my room's lighting is managed by the Apple pod. So I go, Siri, turn bed light on. And it turns on. And then I don't know how to turn it off. It just turns on, and I tell her to turn off. And George gets really scared. He says it's the end of life by the computers.
Rise of the machine, I call it. Rise of the machine.
robots are going to take over. But to me, it's such a practical, simple thing. I just walk into the room, tell Siri to turn the lamp on, and then when I want it off, it just say turn it off, and I go
Those
to bed.
repetitive tasks that can be automated.
You know what? I'm a big proponent of this AI scribing. I've been using it, believe it or not, for about 2 weeks now. I didn't want to touch it, and somebody said, just listen.
Who put you onto this?
Dr. Igor.
Yeah.
He said, just listen, George, stop being stubborn. So I said, okay, I listened with a half an ear, and I tried it. And I'm having I said the only thing that's going to make me faster with all the templates, because I got so proficient with Office Practicum, with templates and the shared phrases and all those things. I said it would be not walking into the room. But you know what? It does help, at least for the story and for the assessment and plan. Everything in between, we still click, I think. It's
well,
good.
in my mind, the biggest innovation that I'm hearing is that there's a focus on patient and physician satisfaction as metrics when you're rolling these tools out, because 6 or 7 years ago, I tried to bring a regular scribe into our practice, a large multi-specialty practice. And the number one concern of the physicians, and the reason that it failed, we weren't able to bring it in, is that they were concerned that it would increase the productivity requirements. And so we were never able to get that tool. And so I think now that things have shifted and we realize that workforce and physician burnout, physician turnover are real costly issues, it's heartening to hear that innovators are really looking at that as an outcome that's important.
Tell me more about the concern about productivity.
So if you can make visits faster because you're removing some documentation burden, then the physicians felt that they would be expected to see more patients in an hour or see more patients in a day.
An MBA
as
would do that.
opposed to
An
just
MBA would
feeling-
expect that, right?
Well, that whoever was paying for the innovation, whoever paid to bring the scribe in, the business would have commensurate increase in productivity requirements. That was really the concern, as opposed to just improving the patient-doctor relationship, improving the quality of care, improving patient and physician satisfaction, which are valuable in and of themselves, right? We talked about the quintuple aim. So we know that they speak to long-term value.
So in the back of my mind, this word keeps popping up, and it pops up on the podcast over and over again. And when I talk to colleagues across the country, relationships matter. So if
Yeah.
your metric is efficiency, sure, I can see 15 kids in an hour. I have a relationship with any one of those families? No. I think I can probably get away with 50% of them living till they're 70. Will I be satisfied with the care as a not just will I come home feeling that I have done something good for society? No. Those families go home thinking that someone's got their back and cares about their children? No. The point you were alluding to, the importance of relationships first and efficiency and volume second, I think is so important in the conversation today.
How many of the innovations that are coming to you are workflow focused versus diagnostic or therapeutic focused?
I would say it's about 50-50. So our Office of Transformation is split down the middle. We have an operational transformation team that focuses on digital tools that help our employees, physicians, and staff. And then we have the digital transformation side that focuses on our patient and family-facing efficiencies and experience. So we're trying to tackle from all angles and figure out where innovation can really help us the most.
And Deepa, would you agree with that breakdown about 50%?
Yeah, I think for KidSec specifically, because we work with a variety of different startups, that breakdown is a bit smaller. I would say it's closer to 20% of the startups that we've seen come our way, and more virtual care, remote patient monitoring solutions are the bigger bulk of companies that apply through our KidSec accelerators. But that's more of a bird's eye view compared to Kiana, who's boots on the ground at CHLA.
And what do you have a sense for why the split that you see is what it is? What information innovators are getting that suggests that they should focus on one thing or another, and how that matches with how you see the priorities from the children's hospitals?
Yeah, every organization has different priorities, and at least with the 30 different children's hospitals we work with, there's a large spectrum of the different structures and innovation departments that are even at these organizations. CHLA, like Kiana mentioned, is part of maybe the later adopter group, but they are one of the more innovative hospitals out there. They have a little bit more of a structured innovation department to be able to support pilots with these startups. On the flip side, we have smaller community-based hospitals that are part of our KidSec consortium that might just have one person as their innovation lead, and they don't really have the money infrastructure to support any pilots, to work with any startups or any new technologies. And so that need is going to be very different from CHLA. And so I think that's why our breakdown is a lot more diverse.
What infrastructure? Oh, sorry, go ahead.
Sorry. So I have a really out of left field question, like I usually do. Because when you mentioned telemedicine and seeing more patients with less pediatricians, and it worries me a little bit, and we've seen it. Roe is a good example of that. Roe is an internet company that started out just to give you erectile dysfunction treatments. Now they moved on to treating your baldness, and now they've gotten into the GLP-1 space. So you just call Roe, you talk to someone on your computer, and if you meet their criteria, they send you their own GLP-1. They compound it. I don't know where they compound it on, and they charge you a monthly fee for that. From a risk adverse place that I come from as a pediatrician and a physician, I tremendously worry about they're doing this for profit. What's it to stop them from putting every 12-year-old in Lexapro and GLP-1s? There's nobody to stop them. And what does that do to the relationship that family used to have with a pediatrician that guided them in less invasive ways of managing their problems? And have we thought about how do we regulate them? And is all innovation great, or is some of it just on naked grab for dollars? Not at the children's hospital. I'm just saying, here's a company that is out there that is doing this already today. They're
Yeah,
not for relationships.
I think you still have to think of the physicians that, I don't know Ro's employment model specifically, but the physicians that are prescribing these medications are still under the expectation that they do no harm. So while they may be working for a company for profit, they still need to make sure that it's clinically appropriate. They still need to make sure that I believe that all telemedicine platforms should have some sort of transcript that they either proactively share with the patient's PCP or that the patient can take and share with their PCP. So there is coordination of care. So while I know that all companies may not necessarily feel like that's on them to take that onus, we do truly believe in making sure that the PCP is a part of the kind of the center or the hub for making sure that all care, virtual or not, is clinically appropriate.
That's an important point, I think, that providers, pediatricians need to understand that instead of being afraid of digital health tools, one of the metrics of quality when we're examining these can be saying, do you connect with the pediatric medical home? Because if a company doesn't connect with the pediatric medical home, you have to ask them why. Are you really trying to do the best care, or are you just trying to make money? And I think the onus is on us as the real owners of these families. I always thought of myself as owning my patients. If we really want to own them and we want to be able to ensure that they have access to care, which digital health helps with, right? Because it's scalable, then our way of intervening should be to ask those hard questions and hold these companies to those kinds of standards.
I'm all about the patient-centered medical home and connecting with the PCP and all that stuff, but I find a lot of these things outside organizations they're all about making a buck or two. They want to connect, so what does that do? They make a buck or two. They give me extra work to do that's unpaid. I'm already busy, and I take all the responsibility. What do you think about that, Sabrina?
I think I have a different point of view. I guess I looked around in my world of pediatrics and felt overwhelmingly any sort of innovation has historically been funded by philanthropic dollars.
Correct.
And the problem with that is when the money runs out, or the PI, the primary investigator, or the champion moves on, the innovation dies on the vine. And so my experience has been that we don't get anything good because there's no money in it. And so one of my theories and biases is that we need to have a sustainable business model in pediatrics. And as long as we are thought of as a philanthropic endeavor, we won't have that, and we won't have good things. So I don't quibble with a sustainable business model. Now, should they be unicorn companies? I don't know the answer to that, but certainly just pediatricians make money and go home and profit from the care that they're delivering. Similarly, I think there should be room for that in the digital health space, but it needs to be tempered by the professionals and adults in the room who can speak to quality, right?
So undeniably, Sabrina, everybody should be able to earn a fair income from the work they do. Very few people are married to Mark Zuckerberg, who's married to a pediatrician, that can just basically do whatever she wants and do good every day. But the role model is inverted the pyramid. As a physician, I prescribe a medication that does not give me a profit most of the time, that is best for my patient if they need it. If they don't need it, I don't use it. The role model is, I got a prescription I want to sell you, and I'm going to have the physician be the salesperson on your behalf because I need that checked off so I can send it to you. That is inverted the formula. Now, I'm not saying they're a bad company or unethical, nothing like that. I'm just saying, is that really how we want to deliver care to our children in America?
You're questioning incentives, right? You're
Yeah.
questioning the alignment of incentives, but I would argue our healthcare system has a similar misalignment of incentives, right? We're incentivized to have visits in person when that may not be the right thing. We're incentivized to refer to specialties when that may not be the right thing. So
And
I
check
don't
a
know. I
lot
mean,
of
that brings
boxes.
up,
And check a lot of boxes. Check, check, check.
yeah,
But don't
So
improve quality.
it brings up an interesting question that I'd love to see if Deepa and Kiana have thoughts about, which is, for me, a lot of the problem with pediatric innovation comes down to the business model, that it's almost that we need a new business model. We need disruptive innovation. I'm curious if that topic comes up around your conference room tables or when you're looking at startups. Is there any signal that is a path forward?
I would agree. It depends on the solution, right? At least from my perspective, when working with startups, we've seen that for them, reimbursement is sometimes really hard, especially if the remote monitoring solution, digital therapeutics, med device, because that landscape is hard because there isn't always, codes built out yet for them to build. A lot of these companies then opt for a direct to consumer business model. And then that's a whole different beast on its own. But I think it's fair to look at the startups and their business models, but also, Sabrina, to your point, I think it's more of a systemic issue, whether it's the healthcare industry or if we're looking at like reimbursement care models in general. They're not built to support a lot of these different business models that the startups are trying to test.
Maybe it's a good time for you, Deepa, to share with us a little bit about the origin story of KidsX. What was the impetus for the creation of a pediatric focused accelerator? And are there specific needs within the pediatric space that spurred that creation?
Yeah, so KidsX was started in 2020, 4 years ago, by Omkar Kulkarni. He is founder, managing director of KidsX, and also CHLA's first innovation officer hire. He still works at the institution as our chief digital innovation transformation officer, but him and many other hospital leaders at other children's hospitals would run into each other at events, conferences, strike up conversations around startup solutions they've tried implementing, systemic challenges that they're facing at their respective organizations, whether it's budgeting constraints, resources, manpower. And those conversations helped Omkar and many of these leaders realize they're essentially all in their own pediatric innovation bubbles. And they're facing a lot of the same issues. And these very organic conversations helped him and the KidsX team realize there really is an opportunity to build and support a community of hospital leaders and hospitals within pediatrics, which isn't necessarily competitive like the adult health space is, really fostering this community that hasn't been supported before from the digital health perspective. And KidsX was really meant to intentionally structure that community and help these leaders connect with one another. And there are leaders like Kiana who are key decision makers at these organizations, director level up, who actually can get buy-in from their organizations to be able to implement solutions. So they get to take advantage of the different offerings KidsX has through our different monthly programs, our accelerator programs. We've also built out programs where, if a hospital system has an idea that they want to spin out to a company, then they can do so by working with a venture studio. So we're really focused on supporting the internal innovation strategies all these different hospital systems have from a bird's eye view.
And so I imagine that there are parts of the accelerator program that facilitate the needs on the side of the providers of the health system. And then there's a part of the accelerator program that facilitates for the startups. Can you talk to us a little bit more specifically about what needs you address for each side?
Yeah.
And what services that you provide?
Yeah, of course. So on the provider side, because we are working with hospital leaders, they're coming from departments like innovation, clinical departments, operations, patient experience, etc. It is a wide perspective of the different needs a hospital would have. And so we host what we call problem identification period at the beginning of our calendar year, where we bring all these different groups of individuals from our 30 plus hospital consortium into one room virtually, and they tell us what their hurdles are, what their priorities are for that year. Our KidsX team facilitates that conversation, and we essentially aggregate the conversations, the data that we collect from this group of people, and really boil it down to 3 to 5 focus areas that make sense for this wide group of children's hospitals. And then once we identify what those 3 to 5 focus areas are, we then look for startups that are actively solving for these specific focus areas to ensure there's alignment from the very beginning. Hospitals are telling us they're interested in AI, or they're interested in more mental behavioral health solutions, more care coordination solutions. So now our KidsX team is really recruiting and working with startups specifically solving for those areas and bringing the two together.
Got it. And is there a sense that there are certain qualities among the startups that apply that predict success? And how do you measure success in your program?
Yeah, I think there's a lot of different ways to ensure there's a startup that's going to be successful. I think a big part of it is, are they actually solving for a problem that's urgent for the hospital system? Is that alignment happening from the beginning? Are they matching what the hospital system was telling us? Do they have a startup executive team that has the right professional experience, has the right personal experience to drive the mission forward? Is there a clear health impact on the solution that they're building out? Is the ROI or the value prop clear to the hospital systems? Is the product properly differentiated from other competitors in this space? Is it innovative enough? Is it user friendly? Has it been tested with the right group of patients or users? So we look at a lot of these different criteria to ensure that startup is, matching that, and then will then be successful, because that's really what our hospital systems are using as a rubric, essentially, to want to work with these startups.
And what about the idea of what's investable versus what is needed? Let me dive into that topic a little bit, because I think it creates some tension, specifically in the pediatric space, because pediatrics, because of small markets and wrong pockets and lots of reasons, misalignments tends to be a less investable proposition.
Yeah. Oh, go ahead, Kiana.
I feel like things that are investable are often things that have big TAMs, big total addressable markets. And often those are disjointed kind of point solutions that aren't being gated, for instance, by some of the things that we just talked about, like with Roe. If you can go direct to consumer and not have to involve the patient's PCP and really coordinate care, then that's very investable. But in terms of what's needed, I would say is tighter care coordination, and then just figuring out who's actually paying for this, who's incentivized to pay for it, who's paying for it. Is it actually reimbursable, to Deepa's point about new remote patient monitoring codes and whatnot? So often those the alignment of what's investable and what's needed still is not quite meeting in the middle.
Yeah, I heard something early in the conversation about a membership fee or something like that. What's the membership fee all about? Who's paying the membership fee? Patients, doctors, startups?
Yeah, so the membership fee is for our KidsX program. The hospitals are paying for it to get access to the different KidsX offerings. It fluctuates on a yearly basis. KidsX is a grant-funded, sponsorship-based program. We rely partly on the membership dollars to really keep the program running.
So can we I want to get into the sort of granularity of the investable versus need question, especially from your perspective too, Deepa, because I would guess that the TAM, say for a care coordination tool for children with medical complexity, that's the population with the largest spend in pediatrics, the largest healthcare spend, but the smallest total number of people. if you use that as an example or any of the other tools, how do you resolve that as an accelerator, investing time and I imagine some resources into these startups that may address a need but may not be promising either a short enough term ROI or a large enough ROI?
Yeah, oftentimes those startups aren't necessarily the right candidates for the accelerator if it's not in alignment with what the hospitals are willing to pay for. Ultimately, we're advocating for the hospital systems, right? They're looking at KidsX to be the thought leaders of tell us what's out in the market, tell us what's happening in the industry, we'll follow your lead. And so we don't necessarily accept those types of companies, especially on a year-to-year basis, if that market is fluctuating. I think also a big part of it is there's a lot of saturation happening within the startup space. Mental behavioral health, I think, is a big market where there's a lot of saturation. We're hoping to see a little bit more consolidation. So I think there's a world where some of these startups that don't have that immediate ROI hopefully can integrate, partner, consolidate with other startups that are in the space. That happens a lot in the adult digital health market where there's a lot of partnerships, acquisitions, mergers. That isn't necessarily the case as often in pediatrics. So I think there's room to do that where companies that have a shorter ROI can work with or be acquired by companies that do have long-term, but they have complementary services. And then together they can work with the hospital system.
Okay, I guess a similar concept to me about this tension of investability and meeting a need has to do with the divide between hospital-based medicine and primary care or ambulatory care in pediatrics, right? So again, to the point about children with medical complexity, that's the population of pediatrics that tend to have the most intersection with hospitals. But the volume, the large majority of children don't have a need for that, but they're intersecting with primary care and with ambulatory care. And so I guess my question is, to what extent, given that your clients per se are children's hospitals, to what extent are their priorities aligned with innovation around primary care or ambulatory care, which ostensibly touches more lives, but maybe has less ROI directly to your stakeholders?
Yeah, honestly, go ahead.
It's okay, you can go ahead. I'll go next.
Oh, I was just gonna say, from the KidsX perspective, there's over 200 children's hospitals that are across the country. We have 30 of them in our network. And unfortunately, majority of them don't have an ambulatory care component connected with them. So it's not something from the KidsX perspective we work with as often, but I'm sure Kiana has another perspective from CHLA.
And since KidsX represents so many different pediatric hospitals, we do have a number of different models. For instance, Children's LA is only specialty care. We have a care network, but we don't necessarily own primary care practices. But other KidsX members have more of a focus on primary care. So it really depends on what our members say is top of mind for that year. And sometimes those are solutions that are more focused on primary care. And we know that CHLA is probably not going to pilot that particular startup because it's not the right use case. But we do still see the need for patient experience, operational efficiency. Primary care and ambulatory care are still facing a lot of the same issues that our specialty care hospitals are. We do source startups and solutions that are solving the gamut of things across our hospital enterprises.
I'm still having a hard time wrapping my head around KidsX. What is it that you guys do, really? You keep mentioning startups, you mentioning hospitals, you mentioned I'm confused.
It's a startup. It would be like if you got 30 big practices across the country, primary care in our world, and they came together and they said, look, we have problem scheduling. And everybody in the room agrees you have problem scheduling. And then the thought leaders, which is X, you guys, will go out and look for innovation and how to schedule better based on the criteria of those 30 large practices from across the country that came with a problem and they want an accelerated solution to the problem.
Okay.
And so
Maybe-
they're curating these solutions for 30 children's hospitals and funding. And once maybe I have a great idea how to do it, they'll coach me up so I can ramp up, so I can deliver the product.
I
Maybe
think
you
that's
could
about
walk us through some of your-
75% correct.
Yeah, let her
So
respond, Herb. That's your opinion.
Yeah, maybe you could walk us through some of your example companies and how you worked with them.
Sure. So to start a little bit more broadly, KidsX, you can think of it as a community. It's a consortium of hospitals who meet monthly to talk about different things, different problems and challenges that we're all facing in the pediatric space.
Okay.
Our flagship program is an accelerator where we say, all of these problems that we've talked about every month, let's source some solutions for them. And we choose what problems we want to focus on sourcing solutions for and run an accelerator. But the KidsX is really a community of knowledge sharing across pediatric institutions.
Okay.
So some of the problems, Deepa, do you want to dive into what we decided to focus on this year and some of the startups that are going to be solving those problems that the hospitals have identified?
Yeah, happy to. So this year we're very much, and I guess before I get into that, I do want to, another way to look at it is KidsX really is the connectors between hospital systems and startups that are in the market. We're facilitating collaboration between both sides of the equation. And so our accelerator programs are designed because we know how hospital systems work. We are using that knowledge to build out curriculum, workshops, discussions to help the startups understand this is how you need to work or pilot with a hospital system. So just think of us as the connectors, if that helps as well.
Like a real estate broker.
No.
Yes, yeah. Yeah,
No,
that's another
they
way to
they're
look
doing
at
much
it.
more. They're doing more.
Yes, and middlemen, in between. Because
Yeah,
startups,
exactly.
they don't have access to the physicians. Physicians don't have access to the startups.
Exactly.
Correct.
Yeah.
I think the value is the people that they have in the room,
Yeah.
that they're all coming up to these are our top 5 pain points. And we think that through innovation, technology, AI, whatever that solution is, we could resolve this.
Uh-huh.
And who do you guys know that is working on resolving this problem? And can you coach them up so they can ramp up to actually be functional at Children's LA? Because Children's LA is a very big place. I could have a great solution, but I'll walk in there and I'll fail. I don't understand how to implement a solution at a hospital that's that size with nurses, doctors, administrators, respiratory therapists, engineers. It's huge. And I may not have the funding to put that team together. So they help you avoid those pitfalls so that everybody wins. The right solutions in place, you cut the problems with implementation, and they've done this many a times. So they know where the problems are going to be before they happen.
Uh-huh.
That's
So
the
what-
beauty of a concept like this. It's beautiful. It's
I
wonderful.
think it's a very good idea because I've dealt with a lot of startups and they come up with ideas that are built by engineers that have no idea what I need. And then they get upset when I destroy their thing. I says, you shouldn't do that. That's terrible. That's stupid. You should do this. I hurt their feelings.
Deepa,
Yeah.
so what are some examples of companies that you've worked with, and how did you work with them? What are the services that your accelerator provides for them?
Yeah, so I can get into the services that we provide and then share. A company that graduated from our KidsX program has also worked with CHLA. I think it'll be a good perspective to share both from my side and Kiana's. But in terms of what we provide, there's essentially 5 main pillars of the work that we provide. Product market validation is a big one. So we help the companies understand what are the trends, how can you position yourselves, how can you pitch yourself in the right way to these hospital systems. There's a lot of pitch practice. There's a lot of value prop workshops that we do with the startups. And then navigating the hospital maze what was said earlier is a big need that the startups have. And so what we've done is we've essentially built a guide, a best practicing piloting guide. And that's been in thought leadership with the hospital systems that we've worked with. We've essentially created a template. These are all the components you need to think about. This is the checklist you need to think about when you're planning for the pilot, when you're in the thick of the pilot, post-pilot. What data do you want to be collecting? What data requirements do you have? What EHR integration components do you have? All that kind of stuff is all in a template that they fill out. And it's a 10-week long process where we essentially help them fill out one piece of that template throughout the 10 weeks. And we assign them to a KidsX champion. So a representative from one of these hospital systems to really handhold them and walk them through the process and champion the work that they're doing. There's also this component of providing mentorship and leadership skills. And so KidsX not only has this built out network of hospital leaders, but we've also built out a network of industry leaders. So people coming from the payer world, investors, other entrepreneurs, and getting them connected to the startups based on what the startups are looking for. One startup might need to be fleshing out their pricing model. Let's get you connected to the right consultant from this firm that we are in network with and have you two work together. So we facilitate those relationships, collaborations as well. And then piloting opportunities is essentially the biggest. We are the only one. And on top of that, we essentially help guarantee pilots with our hospital systems. That's really enticing for startups who are looking to tap into this market that's very underserved. So a lot of our curriculum is, again, built on what are the best effective piloting practices. And so then an example of a company that we've worked with, Diligent Robotics, they're an AI company that have created robots essentially to help healthcare workers with routine tasks. So they graduated our KidsX Accelerator program back in 2020, and they really used our accelerator program to tap into the pediatric market specifically. CHLA was the first pediatric hospital to use their robot and support their workflows, and now there's multiple other KidsX hospitals that are considering piloting or already in the process of having those conversations. So that in itself is the beauty of KidsX, where we're really helping these companies find their place in children's hospitals. So Moxie, the robot, the Moxie robot delivers medications, items on a 24-hour basis. Kiana oversees this pilot, so I'm sure she has more to share around this, but it's really awesome because it saved a lot of time for the staff and a lot of work time, which directly results into dollars and financial incentive. There's over 1,600 hours of work time saved because of these robots. And honestly, really cute. They've designed it where the kids can interact and just have a pleasant experience. It's one of my favorite examples to share, and I'm sure Kiana has some other context to add too.
Yeah, we use Moxie to deliver for pharmacy. We've also rolled out to clinical nutrition and materials management. So a lot of just that time spent by staff walking throughout the hospital delivering things, we can now offload to Moxie so that they can do more high value tasks. And I think that Diligent Robotics really found their niche with peds because, as you can imagine, the patients absolutely love when they see Moxie going down the hall, and Moxie can use QR codes on the elevators to actually go between floors. So it's really been a patient satisfier as well as an operational efficiency play for our staff and clinical team.
And it's a
Let
great
me ask you, you
name.
say it delivers medications. Was Moxie just walk into my room and say, here's your 800 milligrams of Motrin?
So it can't deliver to a patient. You have to scan your badge to be able to retrieve items from Moxie.
Okay.
So you can't just like open the window and take what you will. So there are checks and balances on both sides
So
of
that's a
who's
safe.
putting the materials in and who's taking them out.
Okay.
So,
All right.
so we're 4 minutes past the hour, and I want to be respectful of Kiana's time because I know you have another meeting to get to. So I want to give you the opportunity to drop off and just to tell you it's been so amazing to speak to you. Thank you so much for your time and for sharing your perspective. Innovating in a
Absolutely.
children's hospital.
Really enjoyed it. It was great to speak with you all and meet you all. And I will leave it to Deepa to wrap us up.
Thank you.
Thanks so much.
Thank you
Take
for your
care.
time.
Thanks.
So now we have you all to ourselves, Deepa.
This is where it gets nasty. Now we're going to ask the hard questions.
I'm just curious, is there anything that you feel like we haven't really covered about KidsX, or anything that you feel pediatricians and pediatric providers should understand about pediatric accelerators?
No, I think we covered a lot of the big topics we were hoping to talk about. One thing I guess we can touch on is this year, something new that KidsX is rolling out is a clinical advisory board. So that's something that pediatricians can definitely get involved in a lot more. It's something we haven't done as structurally in the past, but it's a way for clinical leaders to be able to provide direct feedback and work with these startups from their perspective. Obviously, it's their workflow ultimately that may be disrupted by the startups. And so we want to make sure there's an active touch point happening between the two sides. So I think that's more of a call to action. If pediatricians want to get involved from that perspective, feel free to reach out to me. But that's something I'm personally really excited to roll out this year and have as an offering for not only pediatricians who are looking to get more involved in the innovation space, but also for these startups to make sure they're working with the right folks and getting that really important perspective that they need.
I couldn't agree with that more. I've spoken to a lot of digital health founders in the pediatric space, and the common thread theme is always that they cannot reach pediatricians who are the ones who are going to be interfacing with their product. And it's really heartening to know that's something you're focusing on. I'm curious, the clinical advisory board, should that be providers that are within your member institutions, or can it be providers who are simply interested in helping to co-develop or pilot?
Yeah, I think we're definitely open to both. There's obviously, it's easier if it's a clinical leader from our network, because then they can also be the champion for that organization. If it's a clinical leader outside of our network, there's also, if they're involved with KidsX, can better understand the work that we're doing, they can also champion KidsX to their organization. So I think it's a win overall. So we're open to really anybody who's interested.
Great. I love that program.
So I'd like to take a step back because I think you're giving the audience a lot of credit. Most of us pediatricians do not live in California, and these concepts that you have incorporated into KidsX are foreign to us. From what you have told me, it seems like there's multiple layers.
Mm-hmm.
The first layer, you act, DC, we call them think tanks. So industry leaders come together and they express their problems, and they look around the table to see if someone's already solved that problem and they can emulate the solution. So those are your 30-member hospitals that come in and prioritize what their problems are. And then once you have identified your priorities for the year, 5 priorities for innovation, you go out and you seek to partner with some sort of industry, maybe not for profit, but we'll say industry, that may have a solution for those problems. And the third step, which I don't think physicians are very aware of, because this is very much a tech area thing, is an incubator or an accelerator, that's why I asked you whether you had to be resident or you could do it virtually. Because a typical incubator is something like a 18-month program in a shared space. And you have very successful founders. Sometimes they founded 2 or 3 tech companies who lead the incubator. And you have smaller startups in different stages of development. And I may just be starting, not have the funding for a marketing department, but they have the shared marketing people, resources who are going to help me do that. And so you're in essence doing all those 3 jobs in one place. And it's fascinating and very great work. But I don't think most pediatricians understand how much that can help solve a problem. Is that right? Did I get it?
About right. I do want to clarify. So We are an accelerator program. There is a clear distinction between the incubator programs and accelerator programs. Incubators, to your point, are more think tanks. If there's an idea or a concept somebody wants to bring to fruition or build out a product or solution for, the incubator is really focused on getting them to that place, from idea, concept to potential product prototype. Accelerators are more, and what KidsX does, are more for startups, companies that already are established in the market to a certain capacity. They already have a functioning product, a functioning solution. They've already worked with one or two hospitals or one or two clinics or government agencies. They already have one or two customers, but they're looking to build on that and scale their company and take it to the next level. So we're focused on supporting those. Our children's hospitals, what we found is if they know a startup has already worked with another children's hospital in our network, then there's almost this like element of, oh, maybe we should be working with them too. And it's a lot more easier for them to also get the buy-in of, hey, there's Moxie, it's already doing well at CHLA, maybe this children's hospital, maybe we need to start using it. And that's how these conversations start. So it's just a higher level of success that we've seen. So we're focused on that specific part of the innovation equation, if that makes sense.
Yes, yes, yeah. And it seems to me that we talk about this a lot. It's the same problem. It's a problem of the implementation that we see over and over again.
Yeah.
Right now, the pediatric clinician, whether they're inside the specialty hospital or in the community, don't have time, don't have money. There's a lack of knowledge, and there's by nature, we're risk adverse. And then we have anxiety. Like when I asked with Moxie, is Moxie just coming out to my bedside and giving me the Motrin? What if Moxie makes a mistake and I take the wrong medication? But those are the 5 things that you have to address when you're trying to solve a problem through a new innovative technology.
Of course.
And one that you pointed out, which is very difficult because we get asked all the time to review products. And one, it irritates me, they never want to pay for my time. And 2 is when I tell them is this is not at the top of the agenda for a pediatrician. You came up with a wonderful solution for a disease that happens once every 160,000 patients. A general pediatrician has a panel of 1,400 patients.
Right.
They're never going to see this disease. So why would you think that they are going to spend time implementing that solution, changing their workflows? It's a great idea. I love it. It's wonderful. It will help a very limited amount of kids. But from the person seeing depression, anxiety, obesity, type 2 diabetes every day in the clinic, it's not addressing any of those pain points.
Right.
And that's what you said. You want something that they've already addressed the pain point, has already proven that it can make money at it, has beaten the reimbursement or really the payment problem.
Yeah, and there's a pretty competitive selection process that our startups go through. We have over 100 at least applications that come in every year. So the pediatric market, to give some perspective, is somewhere the market value is around 15 million. And the overall, that's the pediatric digital health market. And the digital health market as a whole can be valued anywhere to $10 billion. So this is a drop in the bucket. And even within the drop in the bucket, there's over 100 startups or 200, however many startups that are focused in this super small space. And so KidsX has this responsibility of having to unfortunately filter out all these amazing companies. But to your point, if you've created a solution for a rare disease that's only relevant for 0.5% of the time, unfortunately, that company is very unlikely to be selected for our accelerator program because we're more focused on the big picture. How can we support these 30 plus children's hospitals, which translates over to millions of children? And it's a hard responsibility, but we have to bear that burden as well. And so the criteria process is pretty rigorous. we get, over 100 applications, and there's 8 startups that ultimately get selected and presented. So yeah, it's tough.
I
But
think
it's
you guys, hold
fascinating.
on.
I think you're doing wonderful work.
I think this is fantastic. You guys are doing a great thing, bringing people together. It's all about people, not just computers. People, computers, networks, professionals, computer guys. But Sabrina, what's my favorite question?
Who's gonna pay for this?
Yeah, who's paying for all this?
Yeah. Yeah, the hospitals ultimately have to. I think another thing KidsX is focused on, we don't take any equity. We're a nonprofit program. And so we'll ask the startups, if you want to be a part of our accelerator program, please give a 3-month free pilot for the hospital system. They have to agree to that. They waive implementation fees. They waive any costs for that 3-month trial period. So that's really a time and incentive for the startups to really shine and say, my solution is valuable. This is an easy implementation process. The hospital systems have a 3-month period time to just trial it. There's no commitment that they necessarily have to make, but it's an easier way for them to really test out what's in the market without any cost. And then there's conversations. If that pilot turns into enterprise contracting, then there's conversations around it. But the hope is during that 3-month time, the startup in the hospital system is figuring out what their success metrics are, what is the actual financial incentive. And we found it to be successful enough where we've had close to 60 startup graduate our programs. We've had close to 80 pilots. So that's more than at least 1 pilot per company. So there is a clear match, but that's just been the best way we can try to cater to both sides, because paying for this it's hard. I agree.
Yeah.
There's no easy solution to it.
But then it sounds like the companies coming into the accelerator program need to have the funding runway to be able to support that, right?
And that's exactly why we're working with the startups. We're working with people who are already established enough to have that runway. It's pre-seed to Series A companies that we work with. The seed companies are a sweet spot. So they have a couple million, up to 5, maybe sometimes 10 million in funding already there, or will be in the pipeline. They're at a place where they can scale.
Mm-hmm.
Interesting.
I love it.
You guys
I
are
love it.
doing a wonderful thing.
How long has it been working? Are you 10 years, 5 years?
4 years now, and we've had a
4 years is a
total.
lot.
Yeah, 4 years, and we will be graduating our 7th accelerator program this year. So, yeah, it's been amazing.
Yeah, I think it's just tremendous. I love it. I love it. It's just very exciting. Very exciting.
That's very good.
We had this conversation with George earlier in the morning. I said that these startups, they all start, they have great ideas, and then they come with a product, and then I ask them, and what's your marketing budget? And they look in the sky like, marketing budget? It's a great idea. No, that's not the way the world works.
Yeah.
You might be the most eligible bachelor in the universe. If you don't put yourself out there, nobody's going to find you. And the same with your product. You might have the best solution for a really pressing problem. If you don't have money to market, you're done. Somebody else will buy you out and use your product and sell it.
Yeah, that is true.
But yeah, this is great. This is awesome. Great job.
Very good. Very good. Thank you.
Thank you so much.
Yeah.
So Deepa, it's been so wonderful to have you and Kiana both on the show. I've loved this conversation so much. It's really important work that you're doing. So thanks for joining us and being willing to spend the morning with us.
Yeah, really great to meet you all and appreciate the conversation. Thank you for all the work that you're doing to spotlight all the amazing work that's happening in pediatrics.
Yeah. Thank you. Thank you for your time.
Thank you.
Hope to see